Clear the decks for the Medicare for the Lazy Man podcast. The Medicare podcast that rolls snake eyes every time. As an ATO pledge, he was lower than whale poop at the bottom of the Marianas Trench. It's Medicare expert Doug Jones.
Hello again, everybody. Welcome to another thrill-packed episode of the Medicare for the Lazy Man podcast. This is your Medicare for the Lazy Man podcaster, Doug Jones, and I'm about to plug my books as I do at the beginning of every episode. The reason I like to plug my books is because those of you who are listening who need confidence in the Medicare system and your ability to handle the Medicare system, come out looking like a winner, and come out happy with your selections, you could do worse than to purchase one of my books, probably all three eventually. And my books will convey the information about Medicare that you need in a very palatable way, so as not to take up all of your free time, but to convey the understanding that you're going to want about the Medicare system. So the granddad of all my Medicare books is Medicare for the Lazy Man 2025. You can buy that at Barnes & Noble or Amazon.com. The paperback is attractively priced at about $11. The Kindle is $4.50 at Amazon. The Audible book, I have no idea, but the files are being examined right now. I'm told that Audible is kind of slow in their processing, but eventually you will be able to listen to Medicare for the Lazy Man 2025. And of course, as I always say, if you've got a person on your gift list that's got a birthday or anniversary or whatever coming up, then you can spend $25 on the hardcover version of Medicare for the Lazy Man. And I believe you will have one grateful gift recipient on your gift list. Of course, topping that for the following year might be difficult. New book, Medicare Drug Plans, a simple DIY, do-it-yourself guide. This is a book that will help you select the best drug plan for you. I keep hearing about insurance agents. I listen to a lot of other podcast insurance agents who are refusing to help people select their drug plans, and insurance agents like me who are running out of time and may not be able to reach the people that will need the expertise in selecting the proper drug plan. So I suggest that one purchase the Medicare Drug Plans book at Amazon.com and use it as a tool to go to the website and select the best drug plan for you. There are probably going to be about 14 or 15 drug plans in any given location. And what you will find is that your drug plan choice is going to be based on some variables that only you know about, meaning your drugs. Often the drugs are difficult for a person who isn't well versed, like somebody who's not a pharmacist, to select from the list of drugs available on the government website. The patient is the one who knows best about how the drug is best delivered to them. And the whole point of doing that is so that you pick a plan that's going to work the best for you and will function properly, will cover all of your drugs at your chosen pharmacies at the least out-of-pocket cost to you. And finally, the most recent addition to the library, Medicare for the Lazy Man Bare Bones. Now that is, if you buy the Kindle version of that, which I suggest, $1. That's all it's going to take if you use Kindle on Amazon. If you buy the paperback version, it's going to be $4.60. This is the shortest and most powerful book available in all of Medicare. I recommend to you that if you don't know what the enrollment process is like or why it's set up the way it is, you can buy the bare bones book, and you'll be finished with it in 15 minutes. You will know everything you need to know about Medicare enrollment. You won't have spent much money. You won't have spent much time, but you'll have gained invaluable knowledge. So, once again, $1 for the Kindle version and $4.60 for the paperback version of Medicare for the Lazy Man, Bare Bones. So, anything else that you need to know, you can go right to the website that Randy has created for me, MedicareForTheLazyMan.com, and it will be very obvious to you. You can fill out a questionnaire there. It will come directly to me, and before you know it, you and I will be engaged in genial Medicare conversation, I guess. And I'd like to have conversation with my friend Randy Carson, but he's got new headphones, and I'm not even sure he's listening right now. I see him fiddling occasionally with the settings on the new headphones. It's obviously a source of wonderment to him. Hello, Randy. Are you able to see me? I'm signing at the same time, just in case he can't hear me.
I can hear you, I can see you, and I'm telling you, there are more buttons on these headphones than I've got ears.
God bless technology, huh?
I don't know what to do. There's so many buttons. There's volume, there's tone. I can make you sound like John Wayne. I can do all kinds of things. I can do voice filtering. I can say, I don't want to hear anything outside my headphones. I don't even want transient noise. If I'm going to get hit by a bus, don't tell me. It's just amazing.
That sounds way too much to cope with. I'm pretty sure I don't need that level of technology in my world, but apparently you enjoy the thrill of getting to know a new piece of equipment.
Well, there is that, but it was really a scary thing, Doug.
I'm
You know,
not
a
surprised to hear that.
after we recorded our one of our last episodes last week, or maybe it was the week before, I don't know for sure, but my headphones fell off. I didn't realize they were broken, and I'm
Uh,
going, "Oh my God, I've gone deaf."
well, it turns out you haven't. You're doing very well. I can hear you clearly, and as long as you're still able to follow what's going on this side of the screen, then I'll be fine with that. I wanted to tell you that this is. I want to do a subject today that has come to my attention. It's a scary kind of situation that may be very, very important. And I've got a stack of content here that has been curated for me by the content curator. And so I thought I would clear the decks of all extraneous content and concentrate on this in an effort to get through the whole mess at one time. And if I can't get through all of it today, we'll do it and we'll finish it up in another episode. But this is the imposition of prior approval. The prior approval process has been a huge problem for patients who have Medicare Advantage plans. And when they get sick, if their insurance company is not cooperative, since the doctor that's going to treat them has to request prior approval in almost all cases of major treatment that has to be done, the insurance company is sitting in the catbird seat. And if their accountants say, hey, don't approve that, then the insurance companies will say no to the doctor and to the patient. Well, then what happens? No treatment for the condition unless they appeal. And what happens with the appeal? If the person is well enough and has the energy to appeal and is capable of doing that, eventually the appeals are very, very often successful. What does this tell you? Well, this tells you the company should not have exercised its prior disapproval in the first place if they were going to ultimately approve it on appeal. It's just a way for them to earn a couple of days of interest, or in some cases, 10 days to 2 weeks or 3 weeks of interest on the money that they haven't written a check for yet. So, first article I've got here is changes in prior approval coming to traditional Medicare and to Medicare Advantage. There were two major announcements recently regarding prior approval of treatments and services for Medicare participants. In most medical insurance, many treatments will not be covered unless it's approved at first by the insurer. It's been a source of controversy for some time. Original Medicare hasn't required prior authorization of treatments and services, with very few exceptions. For most care, providers and their patient agree on a treatment. After the treatment, paperwork is for approval and payment is submitted to Medicare. This is the way it should be, ladies and gentlemen. The prior approval process that's unfortunately burdening people who are covered by Medicare Advantage plan is used as much as an accounting tool to conserve monetary resources at the insurance company as it is to save money in superfluous treatment. But I digress. Medicare recently announced that a new model program that will test pre-approval is going to be instituted in various states. The voluntary model program will test pre-approval for some services and treatments, according to a recent announcement from the Center for Innovation of the Centers for Medicare and Medicaid Services. That's the government to you and me. The model program is seeking medical providers to volunteer for the program from January 1st of next year through December 31st of 5 years later. So that's December 31st of 2031. The model will be restricted to these states: New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. Providers who volunteer and are accepted will agree to seek prior authorization for 17 items and services, including skin substitutes, deep brain stimulation for Parkinson's disease, impotence treatment, arthroscopic surgery for knee osteoarthritis. I think that was invented by my godfather, Donald H. O'Donohue, in Oklahoma City. I know he was a big arthroscopic expert, and in fact, he worked on Gale Sayers' knees, put him back out on the field for another 2 or 3 seasons when he might otherwise have not been able to play. A provider who volunteers for the program can choose not to seek prior approval for a case. There will be a post-treatment review of the case, and the provider will risk not being paid by Medicare for the treatment. The government initiated the program and selected the services to be covered because of a series of reports showing waste, fraud, or abuse in certain areas. For example, Medicare spent up to $5.8 billion in 2022 on unnecessary or inappropriate services that had no clinical benefit, according to the Medicare Payment Advisory Commission, which is MedPAC. Under the model, providers will submit the same information they currently submit for payment approval after a service is provided to a beneficiary. The difference is that under the model, the information will be submitted earlier and the provider will wait for approval before performing the services. The government will select companies to receive and review the prior authorizations. The companies will be paid based on the extent to which they saved the government money by stopping unnecessary services. The government said it will manage the program to avoid adverse impact on participants and providers. Of course they will. There was other news about pre-approval, this time involving Medicare Advantage plans. Pre-approval in Medicare Advantage plans has been controversial recently. There have been a number of recent reports and studies that found the authorization process was delaying treatment or causing patients to abandon treatment plans. Other reports indicate that a high percentage of treatments that initially were denied coverage eventually were approved if the patients or their providers appealed the decisions. More than 50 major insurance companies who sponsor many types of insurance plans announced that they will voluntarily streamline the prior authorization of treatments and services in all insurance markets, including Medicare Advantage plans. We'll see how well they do that. They say they're going to have the new process in place by January 1st, 2027. All right, so there's a little picture of the problems that prior authorization can cause. Medicare Advantage plans, prior authorization denial rates. This is an article that is very recent. It was published on the 11th of this month. Will your care be denied? Asks the author. Medicare Advantage insurers use prior authorization to manage utilization and lower costs. How to compare plans during open enrollment. And this is about Medicare Advantage plans. If you're smart enough to have a Medicare supplement plan, it doesn't directly affect you, but it may be coming closer to home than we ever thought it would. If you've never been through the process, prior authorization is a requirement that a health care provider obtain pre-approval or permission from your insurance company to provide a given service. This is true whether you are covered by original Medicare or a Medicare Advantage plan. In 2023, Medicare Advantage insurers made nearly 50 million prior authorization determinations. Original Medicare requires prior authorization for a substantially smaller set of procedures and services than most Medicare Advantage plans do. Medicare services that typically require prior authorization include certain outpatient hospital services, non-emergency ambulance transport, and durable medical equipment. If you are considering signing up for a Medicare Advantage plan, knowing the prior authorization denial rates can help inform your choice. The study that they're referring to here revealed that Humana Medicare Advantage plans had the highest average number of prior authorization requests per member, but the lowest denial. Humana was one of the lowest rated plans by patients, coming in dead last among 3 of the 10 states included in the rankings. So take these ratings with a grain of salt. While they reveal, on average, how many prior authorizations a particular insurer requires, and the denial and appeal rates, the numbers lack some important details. The government currently doesn't collect a lot of data from Medicare Advantage plans, including how prior authorization requests, denials, and appeals break down by type of service or by enrollee characteristic. They don't require reasons for prior authorization denials or what share of Medicare Advantage claims that are denied after service has been provided. That means we don't know what services have the highest prior authorization denial rates or how often certain insurers attribute denials of prior authorization requests to medical necessity more often than others, or how often Medicare Advantage insurers deny patients for Medicare covered services. Medicare Advantage plans must cover all medically necessary services that original Medicare covers. I'm not sure that's entirely accurate. They have to have an actuarially equivalent protection that would be equivalent to Medicare, original Medicare. But it is not necessarily true that they have to cover all medically necessary services that original Medicare covers. For some services, Medicare Advantage plans may use their own coverage criteria to determine medical necessity. Almost all Medicare Advantage enrollees, 99%, must obtain prior authorization for some services. These are typically higher cost services such as inpatient hospital stays, skilled nursing facility stays, and chemotherapy. And these are the kinds of things I don't think anybody would want to have delayed if the prior authorization was turned down. That's me editorializing again. Prior approval determines if the service is medically necessary and should be covered by the insurance plan. Humana and Anthem/Elevance Health both had the highest number of prior authorizations per member, but the lowest denial rates at around 3.5 to 4.5% respectively. So listing a whole bunch of the biggest companies, we've got prior authorization denial rates of 3.5% for Humana, 4.3% for Anthem, which is becoming Elevance. Centene, big company, 13.6% of their prior authorization requests are denied. For Blue Cross and Blue Shield plans across the board, it's about 6%. All other plans, it's about 5.3%. Cigna's 7.7%. CVS, 11%. United Healthcare, 9.1%. Kaiser Permanente, 10%. So Medicare Advantage plans, prior authorization and denial rates, and success of overturning denial on appeal. So in 2023, insurers fully or partially denied 6.5% or 3.2 million prior authorization requests. And let's see here. How many were successful? The share of prior authorization denials that were overturned. I'm reading down the list of these companies: 64.9%, 71%, 70%, 80%, 86%, 85%, 42% for Kaiser Permanente, 89.7% for CVS and Centene, 93.6% were overturned when the patient appealed. Now, that assumes that the patient was able to mount an appeal, follow the instructions for a legally correct appeal. And frankly, the patient could not have been comatose if that were the case. So, frankly, look at the amount of the appeals that are overturned, or the amount of the denials that are overturned when appealed. And I think you see that these companies are denying treatment just to delay treatment. And they also know that a certain number of the patients are not going to appeal. Maybe they're comatose, maybe they died, or maybe they decided to pay for the treatment themselves, or they decided to go without the treatment. So the approvals came for a much smaller number when they eventually came as a result of appeals. So the future of prior authorizations beginning in 2026, Medicare Advantage insurers will publish certain prior authorization data on requests, like denials, requests, appeals on their websites. But detailed data will not be reported. So why bother? Okay, so next article. Prior authorization coming to traditional Medicare. This is the reason we're doing this special edition of the Medicare for the Lazy Man podcast today. Why would we want to add prior authorization to traditional Medicare? After all, one of the joys of being covered by traditional Medicare is not having to put up with the kind of stupidity that Medicare Advantage plan members have to put up with. So here's this article about prior authorizations coming to traditional Medicare. It's a pilot program. The Centers for Medicare and Medicaid Services, that's the government, they're going to implement a prior authorization requirement for certain traditional fee-for-service Medicare services in 6 states starting next year. And I've listed those 6 states for you. Original Medicare has historically required little in the way of pre-authorization, and the change will go into effect January 1st of 2026. The model being implemented builds on a change to prior authorizations rolled out by the government back in June of 2025. That was just a couple of months ago. So you know the 6 states. They call this the WISER model. It's an acronym for wasteful and inappropriate service reduction. WISER. It's meant to test the use of enhanced technologies such as artificial intelligence and machine learning. And that's encouraging, isn't it? Here are 17 services to be subject to prior authorization under original Medicare in those 6 states. It's a, once again, pilot program. And I'll read the 6 states again in case you didn't pay attention the first time. I know I wouldn't have, but here we go. New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. And this is going to start January 1st of 2026, and the program's going to run for 5 years. Here are the 17 services to be subject to prior authorization. Electrical nerve stimulators, sacral nerve stimulation for urinary incontinence, phrenic nerve stimulator, deep brain stimulation for essential tremor and Parkinson's disease, vagus nerve stimulation, induced lesions of nerve tracts, epidural steroid injections for pain management that would exclude facet joint injections. I don't know what any of this means. Percutaneous vertebral augmentation, PVA, for vertebral compression fracture. Cervical fusion, arthroscopic lavage and arthroscopic debridement for the osteoarthritic knee. Hypoglossal nerve stimulation for obstructive sleep apnea, incontinence control devices, diagnosis and treatment of impotence, percutaneous image-guided lumbar decompression for spinal stenosis, and skin and tissue substitutes. Now, two subcategories under that: application of bioengineered skin substitutes to lower extremity chronic non-healing wounds, and wound application of cellular and or tissue-based products, CTPs, for lower extremities. Critics come from both political persuasions, so I would be a critic of them instituting this, and apparently my political enemies feel the same way. So far, there's been criticism from both the left and the right, and for similar reasons. It's baffling how, in one breath, the administration is trying to take a victory lap on insurers streamlining prior authorization in Medicare Advantage, and in the other, instituting the same delay tactics in traditional Medicare, said a Democrat from Washington, whose state will be testing out the new model. From the right, Michael Baker, Director of Healthcare Policy at the American Action Forum, also hit President Trump on his promise to reduce prior authorizations, and he added a dose of skepticism about AI's ability to help the situation, adding a duplicative third party to the already established Medicare administrative contractor network, particularly one that may be using untested artificial intelligence, machine learning, or algorithmic decision logic, may only increase the overall administrative burden and delay beneficiary care. How common are prior authorizations in Medicare and Medicare Advantage? Well, as it stands, traditional Medicare requires prior authorizations for a substantially smaller set of procedures and services than most Medicare Advantage plans. Medicare services that typically require prior authorizations include certain outpatient hospital services, non-emergency ambulance transport, durable medical equipment. For 2023, just under 400,000 prior authorization reviews for traditional Medicare participants were submitted to the government. The situation is very different for Medicare Advantage plans. While they must cover all medically necessary services that original Medicare covers, and we've already been around the block on that one, for some services, Medicare Advantage plans may use their own coverage criteria to determine medical necessity. Almost all Medicare Advantage enrollees, 99%, must obtain prior authorization for some services. These are typically higher cost services, as inpatient hospital stays, skilled nursing facility stays, and chemotherapy. And finally, Democrats question Dr. Oz on Medicare prior authorization pilot. The CMS plans to, that's the government, plans to do the trial thing. In brief, the Democrats are raising concerns about it. The pilot will go add new red tape to the federal insurance program that could delay care and worsen outcomes, say the Democrats. And the CMS Innovation Center announced in late June it planned to try a new program. We've been down that road. Looks like this article we can dispense with right away. A group of Democrats is seeking answers from Dr. Oz as to why the administration is trying to weave prior authorizations into traditional Medicare, and it's not happy about it. Well, neither am I. I find myself oddly in lockstep on that particular issue. And the final article I have today, why a two-tiered Medicare system may be on the horizon. This is the scary thing. You get the camel's nose under the tent, and the camel is able to use that little purchase to increase his influence and get his whole body inside the tent. So this article says physicians treating Medicare patients have seen their real income drop by more than 33% in the last 10 years, fueled by stagnant reimbursement, growing Medicare Advantage enrollment, and surging operating costs, according to a report published August 18th. As financial pressure mounts, some health systems are pulling out of Medicare Advantage entirely, and more physicians may soon scale back their Medicare panels or exit the Medicare program altogether. So here's a question and answer that were lightly edited for length and clarity. Question: with physicians losing more than a third of their Medicare income since 2016, how close are we to a tipping point where treating Medicare patients becomes financially untenable for most practitioners? And the answer, this answer was provided by Mead Monger, PhD and CEO of Omniscient Health co-author of a report about what these converging forces could mean. So this person answered, doctors are caught between a rock and a hard place. Medicare patients make up a large part of many medical practices. This is a double-edged sword for healthcare providers. Opting out completely from Medicare would inevitably inflict serious volume reduction issues, but serving Medicare patients causes financial hardships for the doctors. To get on stronger financial footing, doctors could drop the Medicare Advantage plans that are their biggest loss leaders. We're already seeing health systems reaching a breaking point. The Healthcare Financial Management Association found that 19% of health systems have stopped accepting at least one Medicare Advantage plan, while another 61% are planning to do so or actively considering it. Nevertheless, if the gap keeps widening between cost and payment, more doctors will be forced to scale back on Medicare patients, shift the practice focus away from seniors, and or reduce their patient panel and cut overhead on other costs. Here's another question. If current Medicare Advantage payment and administrative trends persist, could we see a two-tiered Medicare system emerge where seniors on Medicare Advantage plans have far fewer provider choices than on traditional Medicare? Well, that's kind of a stupid question because that's what happens. Medicare Advantage plans always subject you to a list of doctors and hospitals that you're allowed to use called a network. So with Medicare, with original Medicare, you can go anywhere you want as long as you find a doctor that accepts Medicare assignment, and that is something like 95 or more percent of all medical doctors. So this is a silly question. The answer is it's unclear how many providers understand how much they're paid or how much less they're paid from Medicare Advantage versus traditional Medicare. Naturally, as they develop a better understanding of the cost and payment imbalance and realize the negative impact on their ability to cover their costs by treating Medicare Advantage patients, this could very well lead to more of a two-tiered Medicare system. The challenge will be balancing the increasing patient demands for Medicare Advantage versus the declining physician demand for Medicare Advantage. Question: given that commercial insurers often benchmark rates to Medicare, how might this reimbursement decline ripple out to the broader healthcare payment system? There's another question. What are the potential downstream effects, for instance, on emergency department overcrowding, patient outcomes, healthcare spending, if seniors increasingly delay or forego care due to restricted access? The answer: seniors may face a grim future. Now, this is not what we want to hear. If the inadequate reimbursement rates continue, the trend will lead to less patient access to healthcare providers because of a shrinking population of physicians willing to accept Medicare. In turn, it will increase emergency room visits because of requirements to treat all patients. Deferred diagnosis, treatments, chronic disease management, and drive avoidable complications with worse outcomes, including higher mortality and poorer quality of life due to functional decline. At the same time, deferred care will drive higher costs for treating for sicker patients. And the final question: if current trends continue, what will the Medicare physician landscape look like in 10 years? Answer: extrapolating the last 10 years over the next 10 years would not be even financially sustainable for healthcare providers. There would be different impacts based on the types of physicians. Some physicians see more elderly patients than others based on specialty. Physicians employed by health systems are also directly affected. The American Hospital Association estimates that hospitals have a negative 13% margins on Medicare services. Medicare services constitute 25% of hospital care, and commercial insurance covers 37%, according to the American Hospital Association, with payments negatively impacted by declining Medicare rates. A continuation of past trends into the future will essentially wipe out operating margins. All right, so this is not saying that things are going to be bleak for sure, because our economic growth has been a powerful engine and it covers a lot of sins. It will make things easier to budget for increases in benefits, but it doesn't make it any easier for Randy and I to stay on our projected schedule of a 30-minute podcast episode. And I think I've already blown that for today. So I'm going to say thank you for listening to our special episode about prior authorizations and their creeping into the regular Medicare, the original Medicare program. Randy, it's all urine.
All
Oh, no,
right.
no, it's
Yes,
all
yes.
yours.
Yes, it is. But anyway, let me go ahead. There's a few little things I always need to take care of at the end before we, you know, pack our tent and go. Number one, do not forget this email address. It's a very important email address, dbj@mlmmailbag.com. You can reach out to Doug using that address. Don't forget, Doug is licensed nationwide to help you with your Medicare supplement planning. MedicareForTheLazyMan.com. That's where you can go find a website that's got some really cool stuff on it about Medicare, if I do say so myself. We would also appreciate it if you drop some reviews for us around the internet. They always make good reading for us, and also we're still trying to stay ahead. We want to win. We just don't want to stay ahead. We want to win over the travelogues. Last but certainly not least, thank you. Thank you for joining us. You could have been anywhere else doing anything else, and you weren't. You were with us, which is exactly where we like to have you. But doggone it, you guys never keep track of your time. You have just spent about 32 and a half minutes with Doug Jones, the anti-insurance insurance guy, originally from Oklahoma. Not now. He's living in the low ground. I think it's 758 feet, right?
That's close enough. That's exactly
700,
right, in fact.
758 feet out in the low ground of Illinois, right next to what is that place that you keep talking about this last week?
Oh, where the Democrats have been hanging their hats.
Yeah, the Cowardly Democrat
Yes.
Hotel. Is that the name
Yeah.
of it?
No, it's the Q Center, which
Okay.
which doesn't sound like it makes any sense. Arthur Anderson dissolved. This was all that was left of Arthur Anderson. The Q Center, which used to be the St. Charles Country Club and St. Dominic's College for Catholic Girls. And the content curator spent a semester or two there and decided Catholic Girls College wasn't for her. And so she moved on to the University of Arizona.
There you go. Well, anyway, I am going to go ahead and let you sign off here, Doug, because you always do such a fabulous job, and I'm going to be ready to cut the cord when you're done.
Well, here's the deal. We are so happy to have you with us, and we've gone overtime a little bit today, but I think it was an important subject. So please come back and join us again for our next much shorter episode. We promise not to keep you any longer than we have to entertain and educate. So until we meet again, bye bye.